Good afternoon, everybody. So today my topic is on fibroid, or which is also called as the leiomyoma. Leiomyoma is a benign tumor of the uterus, where and the malignant counterpart is leiomyosarcoma, and the incidence of this tumor is the 20% of the women at the age of 30 have got the fibroid in their wombs, and the 50% of this they remain asymptomatic. The incidence seen in the hospital, the patients are 3%. 70% occur in white, and in the Americans, the incidence is up to 80%. The tumor has a high prevalence between the age of 35 to 45 years. This tumor is entirely estrogen dependent tumor, and the fibroids they cease to grow after the menopause. Now the locations of the fibroid, they are classified into uterine and extrauterine. Uterine fibroids are entirely classified as subserous, intramural and submucous, and the subserous category is 15%. The majority are intramural up to 75%, and submucous are up to incidence of 5%, and cervical fibroids are seen in 1 to 2%. Some other types of the fibroids are the broad ligament fibroid, and one more category is wandering fibroid, where the fibroid migrates from the original site and they can go into the sites like the omentum. So the subserous pedunculated fibroids are of this category, where the fibroid can get detached and go to the omentum. Means in other words, to get detached and to get attached somewhere, the fibroid must have a stalk. Now, this is the SM classification of the fibroids. SM means submucosal, where the 0 stands for the pedunculated intracavitary, 1% less than 50% of the intramural thickness. Second is more than 50% of the intramural thickness, and the third is of the other categories, where 3 stands for which contract the endometrium. The fourth is intramural. Fifth, subserosal, more than 50% intramural. Sixth is subserosal, less than 50% intramural. Seventh is subserosal pedunculated, and the eighth is the others. Now, what is the pathology of the fibroid? The pathology is grossly the uterus is enlarged and the shape is distorted. The cut surface of the tumor is smooth and whitish. The cut section, in the absence of degenerative changes, show the features of a whorled appearance and trabeculations. The false capsule is found by the compressed adjacent myometrium. The center of the tumor is least likely to degenerate. On the microscopic examination, the tumor consists of smooth muscles and the fibrous connective tissue of varying proportions. Now, what are the clinical features in the fibroid? The clinical features are divided into symptoms and signs. Symptoms: the majority of the fibroids remain asymptomatic up to the extent of 75%. Second is abnormal uterine bleeding. In 30% cases, they present either with the menorrhagia, metrorrhagia, or irregular bleeding. The menorrhagia means the cycles are regular, but the bleeding period is increased. In metrorrhagia, the cycles are irregular and the bleeding period is increased. Third, the dysmenorrhea is present. The fourth is dyspareunia. And then they can also present with infertility in case of 30%, where the fibroids lying near the cervix, they cause a barrier to the ascent of the sperms. And sixth is the pressure symptoms, on which the symptoms are due to on the organs on which they press. So either they can be related to micturition or defecation, depending upon the pressure symptoms. Now the menorrhagia, in detail I would like to add about. The menorrhagia is seen mainly in the submucous types of the fibroids. Now the signs. Now in general examination, there will be varying degrees of the pallor according to the blood loss. And secondly, if tumor is more than the 14 weeks, the following features are noted. The first is firm feel, second is well-defined margins, and the third is the nodular surface. Now, what are the complications occur in the fibroids? First is the degeneration, second is necrosis, third is torsion, fourth is the hemorrhage, the fifth is polycythemia, and last is sarcomatous changes, which are rare. Now, a word about degenerations. The degenerations are hyaline degeneration, myxomatous degeneration, and the calcareous degenerations, and red degeneration. Now, red degeneration is most common in the pregnancy. Mainly, the patients have intense abdominal pain, and the treatment of the fibroid during the pregnancy is entirely conservative, where you have to manage with the help of analgesics. And suppose by chance if you open the abdomen, the treatment is just open and close. Now, how to arrive at a diagnosis, or what are the investigations seen? The investigation done. First is ultrasonography, and second is the color Doppler. The ultrasonography is done to see the location of the fibroid, and the color Doppler is done to see the vascularity of the fibroids. Now the next part is the management. Is the first is the observation, second is the medical line, and third is the surgical line. Now observation means, see, after postmenopausal age group, if the patient comes to you, and usually the patients are above 45 years, then after the 45 years, the hormones like estrogen and the progesterone, they get depleted. So and the fibroid is entirely estrogen dependent tumor. So the fibroids usually cease to grow after the menopause. Now one more case is, if it occurs in the young age group, or reproductive age group. So you must, in these patients, they counsel them appropriately for options like myomectomy, after considering the semen analysis of the husband. Then second is the medical line of treatment. The medical line of treatment is, first is GnRH analogs, second is RU 486, then third is iron supplements, and the fourth is dinazole. In today's practice, dinazole is not used at all. Now GnRH analogs. The GnRH analogs, the mainly drugs available are nafralin, buserelin, goserelin, and leuprolide. Then GnRH analogs, they can be used prior to myomectomy. The only disadvantage of the GnRH analogs is they disturb the plane of dissection. So and also prolonged use of GnRH analogs of the more than 6 months can lead to osteoporosis. So GnRH analogs must be used with the caution. Then the iron supplements are given to correct the anemia. Then one more thing to control the bleeding is use of tranexamic acid or epsilon aminocaproic acid. These are used to control the bleeding. So this is the medical line of treatment. And then next is the surgical line of treatment. The surgical line of treatment is of two types. First is the myomectomy, and second is hysterectomy. Now myomectomy is done in the young age group. When the patients are want to plan for a want to plan for a child. So in these cases, myomectomy, the husband's semen analysis must be done and see that his the functions are not normal, and so myomectomy is can be done by laparoscopy, by hysteroscopy, by abdominal method, and by vaginal method. So sometimes during the myomectomy injection, vasopressin can be given to control the blood loss, and then uh, the fibroid is removed in toto, and then the capsule is sutured. Now the surgical management, the other modes for the patients who have completed the family. For patients who have completed the family and the fibroids are causing symptoms, the options are the hysterectomy. Hysterectomy can be done abdominally, vaginally, or laparoscopic assisted vaginal hysterectomy or total laparoscopic hysterectomy. So now the vaginal hysterectomy can be done if the uterus is less than 12 weeks size. And the abdominal hysterectomy for huge fibroids. And so usually a combined approach of today is used, which includes laparoscopic assisted vaginal hysterectomy and or total laparoscopic hysterectomy. So in this, after removal of the uterus, the vagina can be closed by endoscopically or manually by the vaginal stitches. Now, the recurrence of the fibroids, the chances are very less, and usually the malignant chances in the fibroids is also very less. That is, fibrosarcoma is very less. Okay, thank you.